Okay, so welcome everyone to the Human Islet Research Network webinar. Today's talk will be an update on type 1 diabetes, screening and disease-modifying therapies. I'm Joyce Nyland. I'm professor and chair of the Department of Diabetes and Cancer Discovery Science at City of Hope, and also co-PI of the HIRN Coordinating Center, along with John Cadiz. Our presenters today are Dr. Emily Sims from the Indiana University School of Medicine and Dr. Richard Oram from the University of Exeter Medical School. So just to give you a little background for those of you who are not aware of HIRN, this has been going since 2014 and now consists of 5 consortia: the Human Pancreas Islet Consortium, Analysis Consortium, Beta Cell Death and Survival Consortium, the Consortium on Modeling Autoimmune Interactions, the Consortium on Human Islet Biomimetics, and the Consortium on Targeting and Regeneration. And then we are the Coordinating Center at City of Hope. We're called the Human Islet Research Enhancement Center. The program has grown over the years to now over 200 investigators across 85 institutions and 9 countries. I always like to highlight this series that was published early on by HIRN investigators, and the editorial here gives you an overview in molecular metabolism. If you want to learn more about the foundational science going on in HIRN, you could go to this review series. And then I'd like to just highlight our HIRN website. The URL is up at the top, hirnnetwork.org, with just one N at the beginning. And here you'll see our resources about the research, our executive summary reports, and I'll just highlight in the resources you can get to HPAP's PancDB, a publicly available database. IIDP is the Integrated Islet Distribution Program for islets, NPOD for tissues, Pancreatlas for high-level, high-resolution imaging. And then our resource browser, I'll tell you a little more about that in our webinar series that we're in today. So the resource browser is now in version 4. We have over 2,500 resources cataloged and quality assured here: antibodies, technologies, data sets, protocols. So please go to the resource browser. It's publicly available for any researcher, and you'll find a lot of excellent resources there. And then when we have special collections, we publish those as well. Here's tetramers, insulin antibodies, humanized mice that have been specially curated collections. And all these tutorials and webinar videos that we've done in HIRN are recorded in YouTube and posted on the website, as today's webinar will be recorded and posted soon. I also want to highlight our HIRN newsletter is a great resource for you for diabetes research in many areas. Funding, you can follow us and request access to the newsletter if you like. Here's our social media tab. And then hirnec@cityofhope.org is the email address. And when you get to the newsletter, each month it has a lot of excellent features. We highlight different webinars. We give now every month tips for this new NIH data sharing plan that's rather complex and confusing to a lot of people. So ways to help you with tutorials and online tools. We have upcoming meetings, both local and national. And we also post job opportunities in academia and in industry. And importantly, funding initiatives are posted here on the newsletter. We just closed an initiative that we run every year called the Islet Award Initiative of IIDP, where you can get free islets if you're an investigator new to the field of human. So look for that. It'll be coming up again next year. And coming up next month, there will be a couple of currently running RFAs out there. They're due in a month in July. And the first one is called the Technology Resource Awards of the IIDP, where we're looking to fund $150,000 for a year for each award to help us explore the human islet niche and develop research resources and standardized protocols, assays to measure the quality, viability, and function of IIDP islet-associated biomaterials and tissues. You could study unique aspects such as islet interactions and vasculature, neural tissues, and the extracellular matrix, or projects on endocrine exocrine interactions or pancreas immune interactions. Beyond studying islets, you could propose a collaborative study with our IIDP islet isolation centers to explore and validate the handling and defining quality control metrics for non-islet pancreatic and pancreas-associated biomaterials. There's also a smaller award that's posted out there called the Data Resource Trainee Scholarship Award. This is for graduate students, MD students, postdocs, recent trainees to help advance research in human pancreas biology and islets. It provides the trainees with support and access to detailed integrated donor and islet data via the IADP's Research Data Repository, or RDR. We have over 1,400 donor isolations stored out here and the data associated with it. So you could explore relationships among donor characteristics, islet phenotyping, genetic risk, as we're going to hear about today, and help us improve the RDR's future functionality and utility as one of the charges of this award. It's for $10,000 for 1 year. So again, these IADP offerings will be posted on the HIRN newsletter, or you can go to our website at iadp.coh.org. So turning to today's webinar, we are going to be discussing the approaches and broader applications to T1D risk screening and to disease modification with recent promising areas of advancement and the next steps and challenges for successful larger scale application of screening and disease modification. Just as a few reminders, as I mentioned, the presentation is being recorded and will be posted on YouTube. Please mute your audio and cameras during the presentation, and then you'll be called upon after the presentation for Q&A. You can go off mute or go into the chat to ask your questions. And then let me introduce now our two speakers. Dr. Emily Sims is a HIRN investigator herself. She's in the CBDS consortium. She's also an associate professor of pediatrics, a pediatric endocrinologist at Riley Hospital for Children, and a physician scientist in the Indiana University Center for Diabetes and Metabolic Disease. She's also a TrialNet investigator. Her research passion lies in identifying and understanding risk factors that predispose susceptible individuals to diabetes, with the ultimate goal of improved risk prediction and development of novel treatments. Our other speaker is a guest we're very pleased to have today. He's not a HIRN investigator himself. Dr. Richard Oram is an associate professor at University of Exeter Medical School. His research focuses on the biology and beta cell function of T1D and genetic risk factors that predict risk of T1D. He's funded by JDRF, the Helmsley Charitable Trust, and has received a Harry Keene Fellowship. So welcome to Dr. Sims and Dr. Oram, and now I will turn the presentation over to them. Thank you very much for coming, and we look forward to your presentation.
So I'm conscious that when you have two speakers, sometimes there's even a little bit of time lost in the transfer from one person to another. So I'm going to crack straight on. I would highlight that it's a pleasure to come and be a visitor to this meeting and talk about screening. I'm aware sometimes when I go to meetings not in my area of specialist interest, I need a very gentle run-in. So apologies to the experts who already know a lot about screening on this call. I was going to start relatively simply and talk about higher level concepts, really as a kind of warm-up act to Emily, who's going to probably talk about the hottest topics in this area, in this field at the moment, which is the significant strides forward made relating to therapies, which now look like they may delay or possibly in the future prevent type 1 diabetes. So that's just how we're going to split this, with me speaking first. Okay. I thought I'd just give a background on screening in kind of healthcare in general. And I don't know about you guys, but sometimes when I want a general explanation, I go to Wikipedia, because sometimes the summaries are good. And actually their summary on screening was pretty good in terms of how they described it, where you're essentially looking to diagnose conditions which haven't yet been clinically diagnosed normally using risk markers of some form or other. And you can apply that either to individuals at risk. Say if you have family members of someone with a disease, you might want to screen those specific individuals, or you can apply screening to whole populations, as is the case with say cardiovascular risk screening, some types of cancer screening, and newborn screening, which we'll come on to at the moment. And commonly people don't exhibit signs or symptoms of the disease at the time. Okay. There are some examples in modern medicine at the moment, some particularly good ones. And actually, there are some slight differences between adult and pediatric screening. But if we think about adult public health screening across populations, that includes a variety of different types of cancer screening. It also includes cardiovascular disease screening. And then in the pediatric setting, Emily's home territory, there's a raft of diseases which are tested for at birth with a newborn heel prick test, such as congenital hypothyroidism, cystic fibrosis, and congenital adrenal hyperplasia. One interesting difference really is that adult risk screening sometimes risk stratifies people into groups dependent on, say, blood pressure, cholesterol, or other soft markers of cancer, which don't make a diagnosis but may progress you to more invasive testing. And so in adult medicine, we're relatively familiar with kind of risk stratifying people. Most pediatric diseases that are screened for are more deterministic in the testing. And so newborn screening tests commonly quite rapidly get you a clinical diagnosis, which then often has a specific treatment identified, which mitigates the severe consequences of that disease. Congenital hypothyroidism being a particularly good example, where it's a simple diagnosis, it's easily treated, and that early diagnosis prevents really quite severe cognitive issues which would otherwise be manifest. Okay. And one thing that's really important to recognize, and actually having worked across international borders in different healthcare systems, it's interesting that the harms of screening are sometimes viewed differently in different countries. But there are potential significant harms of screening, which we may well come to in the discussion after this presentation. They include overdiagnosis, where you diagnose people with mild disease who wouldn't otherwise need treatment, or misdiagnosis, where people get labeled as having a disease or being high risk but don't have disease. There are adverse effects of the screening tests themselves, and sometimes the wrong people are actually tested. And this is even in the setting where we might instinctively feel that screening would be great. And there's been a long-standing debate, for example, around breast cancer screening and whether mammography, certainly in certain specific age groups, actually identifies more cancers which would progress and would need early treatment versus diagnosing cancers or non-cancerous lumps which otherwise wouldn't need treatment. And you can see this triangle thinking about benefits, cost to healthcare systems, and then also potential harms of screening, which are always worth thinking about and sometimes underrepresented when we first think about screening. I'm sure most people on this seminar will be familiar with this slide, but I've gone back to this mainly just to highlight that some of the concepts we have in type 1 diabetes that are important for screening, the groundwork was laid for them decades ago, and we still, there are still quite a lot of similarities to the way we think about screening for type 1 diabetes that result from this slide, this very well-known slide from George Eisenbarth, which highlights that there's a genetic predisposition to type 1 diabetes, some kind of triggering event, the development of autoimmunity and the beginning of type 1 diabetes pathogenesis, but this could take months or years before clinical diagnosis, which you can see with the dotted red line here. And then you get clinical disease and still progression of disease after this point. And it's this preclinical phase which makes screening theoretically possible in type 1 diabetes and still underpins our screening strategies today. I was discussing this talk with Emily some days or weeks ago and thinking, well, why would islet biologists care about type 1 diabetes screening? And I think this very, very early peak or blush of autoimmunity that occurs before the age of 1 year, peak around 9 months, is still something we don't fully understand. But I think the interaction with beta cells and islets is something we need to do further work on. So this slide highlights that autoimmunity quite commonly begins early. That's the red line of new incidence of autoantibodies. This is data from the NIH-funded TEDdy study, and it really shows this peak incidence in early life, mainly driven by insulin autoantibodies. I also study monogenic autoimmunity, specific genetic mutations that cause severe autoimmune disease. And oddly, beta cell autoimmunity is commonly the first presenting feature in these diseases. And we still don't understand why beta cells are so visible to the immune system, that this process, that a systemic defect in the immune system can cause type 1 diabetes, sometimes alone. So I really feel we don't fully understand why beta cells specifically are visible to the immune system so early. And even if we have systemic defects in the immune system, commonly type 1 diabetes is the first presenting feature, and occasionally the only presenting feature. So how do we define autoimmunity in asymptomatic type 1 diabetes? It's with islet autoantibody screening. Many on the call will be familiar with this. We know of 4 key autoantibodies that are measurable and are commonly used for screening. They're listed here, and they are key beta cell proteins. The first islet autoantibodies that appear in people developing type 1 diabetes are commonly insulin autoantibodies, or GAD65 antibodies, with IA2 commonly appeering as a second autoantibody. This slide here, I think, was important to include as it sets the scene for how we now define type 1 diabetes. And this study is kind of commonly cited. This was a meta-analysis of 3 screening studies beginning in early life. And this particular graph here from the paper highlights the risk of progression to type 1 diabetes in people who are single antibody positive, 2 autoantibody positive, or 3 autoantibody positive. And it's those multi-autoantibody positive individuals, the top 2 lines here, who almost all progress to type 1 diabetes, around 80% by the age of 18, that really moved the field towards defining stage 1 type 1 diabetes as the presence of 2 or more autoantibodies. I think this is relevant to islet biologists if you're lucky enough to get samples from people who are antibody positive but don't have clinical disease, and you're trying to study early disease. Because what you have to remember is that if you get multi-antibody positive individuals, they're most likely to progress, although this may be, or they have stage 1 type 1 diabetes. You could make an assumption they will progress in the vast majority of people. And this is in contrast. Another thing to highlight is this could take years, as you can see from the slide, and this is in contrast to single autoantibody positive. Now, single autoantibody positive people are more numerous in the population, but their risk of progression is less than 20%, closer to 10%. And so you have to remember, if you're studying islets from individuals who are single antibody positive, there's a kind of philosophical kind of there's philosophical thinking that needs to be done as to whether these people have autoimmunity at all, whether they're a false positive autoantibody, and what abnormalities in these people mean. So as a result of that study and other similar studies, stages of type 1 diabetes were defined, with stage 1 being people who are multi-autoantibody positive but with a normal blood sugar. Stage 2 being individuals who had an abnormal blood sugar but also 2 autoantibodies, and stage 3 with clinical diagnosis of disease. And this reinforced this aspect that type 1 diabetes has a latent preclinical phase. And this is potentially important if you're going to screen for disease. In the interest of time, I won't go into the specific evidence relating to the case for screening for type 1 diabetes, but there are several key themes. Top of this list would be that even before interventions have arrived, diabetic ketoacidosis at onset, which is a severe, life-threatening and sometimes life-ending event in a small subset of children, can be reduced dramatically by screening. If you know you're at high risk of progressing to clinical type 1 diabetes, often the delivery of education and the knowledge that a child is at high risk means that you end up with earlier recognition of symptoms of diabetes, and you avoid presenting with diabetic ketoacidosis. Whilst the number of lives saved would be relatively modest, you have to remember that type 1 diabetes is actually more common than many rare diseases that are used, for example, that are screened for in pediatric newborn screening. So that tiny number of infants or children who die presenting with diabetic ketoacidosis is probably similar to the numbers who die from those severe but rare pediatric diseases that we screen for in newborn screening. There's a second but related point that you end up with a smoother progression to diagnosis of clinical type 1 diabetes, with this kind of safe landing, meaning earlier delivery of education and counselling about what the future holds and what treatment options are available. Obviously, our understanding of the natural history of type 1 diabetes is in large part related to screening studies that have studied individuals at high risk. And the bit that Emily is going to come on to shortly is that now there are these opportunities for intervention that may well be more effective delivered early in the disease process. Okay, so who should be screened for autoantibodies? Well, there's a practical element to this, that screening with autoantibodies is expensive. And if you screen whole populations, the number of people who are positive when you do a screening test will be relatively modest. But if you enrich before you start the screening process, you'll end up with a better bang for your buck. And so early natural history studies trying to understand the natural history of type 1 diabetes and identify people for intervention trials often focused on relatives. The reason for this is they're easy to measure. You don't have to do a biomarker. You don't have to do any test to identify relatives. They're in clinic, and they also understand the disease because they have a relative with type 1 diabetes. So there is a great efficiency in studying and screening relatives of individuals with type 1 diabetes. And an example in the US would be the TrialNet Pathway to Prevention study. The downside to this is that only 10 to 15% of type 1 diabetes cases have a relative affected. So when you screen relatives, you're only focusing on that 10 to 15%. Another approach would be to screen whole populations with autoantibodies. And there are some great examples in the moment, both in North America, Europe, and elsewhere. An example of the largest screening study to date of a whole population would be the FRIDA study led by Annette Ziegler in Bavaria. And then an equivalent in the US would be the ASK study based in Barbara Davis in Colorado. I'll come slightly later to using genetic risk as a kind of pre-screen, which has been used in natural history studies like TEDI actually across North America and Europe, the DIP study in Finland, and then come to genetic risk score screening. So just a couple of notes on autoantibody screening. FRIDA, as I mentioned, is one of the largest efforts at general population screening, and highlighted, well, one, how good this particular study was at accessing children. It managed to recruit over 150,000 at the point in time I took this, from the publication I took this slide from. Now it's probably more. They screened children between the age of 1.75 and 10 years, and they tested with a screening test for all autoantibodies and then confirmed the positive result with further testing. You can see the yield of a test like this, screening over 150,000 children, with 0.2% being identified as stage 1 type 1 diabetes and significantly fewer being stage 2 or stage 3. So it did identify multi-autoantibody positive infants, but they were 0.2%. And so the yield from this is just worth bearing in mind. Effectively, that's just under it was just under 300 children, I think. Okay. Looking at the cost, just so you get an idea of this, it was around $30 per child screened and around $9,000, I think, per case of type 1 diabetes identified. One of the real challenges, if we think about that kind of screening approach, is when to screen. I highlighted that type 1 diabetes autoantibodies often have their incidence early in life, but also that incidence continues throughout childhood. So any age you choose to screen at runs the risk of missing children who present before that age, who present with their diabetes before that age, and it will miss children who develop their autoantibody after that age you screen at. And there's significant effort that's gone into trying to pick the best ages for screening. Here is an example from a consortium called TIDI. This paper was written by an IBM researcher called Mohammed Galwash, Bill Hagopian, the senior author, and they effectively looked at sensitivity and specificity from aggregated screening studies, 5 screening studies in total. And just to highlight, if you look at the sensitivity, the number of all type 1 diabetes cases in childhood, or the proportion that you find with 2 ages, you still end up with numbers that are around 50 or sometimes 60% if you're lucky, okay? And also that if you have multiple islet autoantibodies, your chances of developing type 1 diabetes by the end of childhood are represented here. One thing they highlighted was also, depending on where you are, the correct age to screen at may be different. It looked to them, in fact, with these data, that in Finland, for example, screening at ages 2 and 6 was most effective. You can see that here with the combined sensitivity being higher than age 2 and 9. But in Colorado, the opposite was true. And in fact, in the USA, maybe the ages of 2 and 9 would be the best ages to screen. This depends on the kind of national incidence of new islet autoantibodies and makes it complicated to think when you would screen. Also, it makes it expensive if you have to do it more than once in a whole population. So that just highlights one of the challenges about screening childhood cases, and we haven't even got into the fact that we know less about adult type 1 diabetes and how to predict that. The other point I wanted to make about screening was that you can use a genetic pre-screen to identify individuals at risk and maybe target autoantibody testing to those individuals. The benefit of this would be you need to not necessarily screen the whole population, but focus on those individuals at high genetic risk. It's almost like a kind of relatives plus, but with a, you know, with a better marker of genetic risk than relative status. And this was one aspect that I've got into myself, mainly using genetic risk scores where you aggregate information from lots of variants using maths that initially even I could understand, where you effectively take each variant, you decide whether or not you've got 1 or 2 copies of the allele, and then you add those up on a scale to develop a type 1 diabetes genetic risk score. That effectively allows you to place any individual in a population on a continuum of disease risk, from low risk to medium risk to high risk. And you could then draw a line somewhere in this distribution and target people above a certain risk threshold. And type 1 diabetes genetic risk scores actually discriminate type 1 diabetes pretty well. This is a kind of diagnostic biomarker kind of 101 teaching slide, highlighting when you compare cases in blue to controls of the disease in red, that you effectively look at how overlapping the distributions are with something called ROC analysis. And if a biomarker is hopeless and doesn't discriminate disease, then the distributions are overlapping and you get a ROC AUC of true positives against false positives of 0.5. That's a hopeless test, no better than random chance. Your perfect diagnostic test would be a ROC AUC of 1, straight up, straight across, true positives in 100% of people and no false positives. So in type 1 diabetes, the ROC curve looks pretty good, especially with the most modern scores. You can see here, this is from a paper by Seth Sharp, highlighting a ROC AUC of 0.93 effectively, bearing in mind this is a European ancestry population with some limitations around that. So a genetic risk score for discriminates type 1 diabetes well. And my colleague Bill, and actually our colleagues in Germany, used this in two different settings. My colleagues in Germany in a study called GPAD focused on the highest genetic risk infants to select those infants for intervention trials in early life. So they were trying to take the 1 in 1,000 infants with a risk that was between 10 and 20%, actually closer to 10% with the particular risk score they were looking at. This is data from a more recent risk score. The downside to picking those 1 in 1,000 babies to then follow up with antibody testing is the sensitivity. The number of type 1 diabetes cases in childhood you would identify is only 7% of all cases. So this wouldn't be good for public health screening. My colleague Bill had an opposite approach. He wanted to be more generous with a cut through the population, maybe taking the top 10% of infants. And in doing that, you could identify around 80% of all future type 1 diabetes cases. But there's an important caveat here in the title of this slide, which is even those people identified at high risk most likely aren't going to get type 1 diabetes. So genetics isn't good enough in its own. It has to be combined with other things. And the studies that have kind of been born as a result of genetic risk score efforts this time, in the past, HLA typing, was the idea that you'd do this newborn genetic screen in early life, and then you'd target infants at high risk for follow-up autoantibody monitoring, which is still absolutely needed. But maybe there's a cost saving in only having to follow the 0.1%, the 1%, or the, where can't we? Emily's just kind of looking at my timing, but I think I'm nearly there. Essentially, there's an efficiency to only following those high-risk infants. In fact, it was my colleague, Loic Ferrat, who took genetic risk score data and then developed a combined model using genetic risk scores, autoantibodies, and other risk factors to identify the kids at highest risk from birth in the TEDdy study and simulate what would happen if you followed just high-risk infants, updating their risk as they went through a screening program, and highlighting that you could start with 10% of infants, but partly because new autoantibodies appear in early life, you could reduce this 10% down to 1% by the age of 10 and only be following a small subset of the population, but still capture nearly 80% of all type 1 diabetes in a perfect world. And now there are multiple from birth type 1 diabetes prediction efforts kind of moving forwards that leverage genetic risk in a variety of settings and sometimes in comparison to autoantibody testing alone. And I'm just showing you an example of some of those here. So the kind of summary from my bit of the talk is that type 1 diabetes has a potentially long latent phase defined by autoantibodies. Screening helps study natural history. That's what it's been used for in the past. It prevents diabetic ketoacidosis, which can be life-threatening and life-ending. And it identifies individuals for interventions, which is going to form the focus of the second half of this talk, and actually what makes this a hot topic. You can screen family members, whole populations, or those identified at genetic risk. And the risk and benefits and implementation are still in evaluation. So I'll stop there and hand over to Emily. Thanks.
Hi, guys. So here is an outline for my section of this talk. So first, I'm just going to do an introduction to the idea of disease modification, and then only have 20 minutes. So this is going to be a bird's eye view highlighting some kind of promising treatments that have been in the news recently in our field, and then talk a little bit about challenges and next steps and how we think they might apply to people in the HIRN. Okay, so a lot of times when people are thinking about disease-modifying therapies and type 1 diabetes, they say, well, why do you really need this? Because we have a great therapy for type 1 diabetes, which is insulin. However, unfortunately, really, we still have a lot of strides to make in our care of patients with type 1 diabetes with insulin. So we know that still, even with all of the advances with insulin, in terms of delivery methods, in terms of glucose monitoring, in terms of newer insulins that are more physiologic, there's a lot of morbidity and mortality that's still associated with type 1 diabetes. People still get micro and macrovascular complications, especially people who aren't kind of meeting glycemic targets. You can still have pretty severe hypoglycemia due to insulin treatment. We know that hyperglycemia over time in kids is probably not, or has some negative effects on the developing brain. And then, as Richard brought up, especially at the time of diagnosis, people in the United States have really high rates of diabetic ketoacidosis, which can be life-threatening and cause lifelong implications on hemoglobin A1C. Even if you're kind of meeting A1C targets and everything is perfect with your diabetes, this disease is associated with considerable cost for families and patients to get all of those supplies and insulins. And then additionally, there's just this kind of mental health burden on people who have this disease in terms of all of the decisions they need to make related to their glucoses and their insulin. So what about disease-modifying therapies? This is really based on this idea that insulin is really just treating a symptom of type 1 diabetes. But if you target interventions that are looking or addressing underlying pathophysiology of type 1 diabetes, you might be able to prevent, delay, reduce, or reverse the need for insulin replacement. And this is a slide that Laura Jacobson from the University of, or from Florida gave me. So thanks, Laura. That has lots of different mechanisms of disease of type 1 diabetes. And it's kind of complicated, but I didn't show it to kind of go through all the different mechanisms, but just highlight that really all of the different therapies that we test are kind of targeting different parts of this process. And so something that you'll see is that many of these therapies are targeting the immune system. It makes sense, right? Because type 1 diabetes is an autoimmune disease. And so I think we really need to kind of get comfortable with the idea of immunomodulation or immunotherapies if we're really going to target underlying disease and type 1 diabetes. And I think the good news here is that even though this is a paradigm shift in terms of our care of these patients, there's really great long-term safety and efficacy data using these therapies in other autoimmune diseases. So, doctors who treat inflammatory bowel disease or rheumatologic diseases, even in pediatric patients, have lots of experience and really great long-term outcomes in terms of patient quality of life with these kinds of drugs. Here's another kind of complicated image showing a graph of what I feel like are some interventions that have shown success in larger trials. And so again, I'm not showing this to kind of have people look at every single piece of data on here, but highlight a few kind of commonalities. A lot of these drugs are targeting, again, the immune system. But additionally, something else you'll notice is that a kind of common strategy in testing these kinds of therapies is to start in new onset disease. So people who have been diagnosed with clinical type 1 diabetes. And really not very many drugs have been tested in the prevention population or early stage disease. And this is because of a couple of things. One is that it's really hard to identify patients who are at risk or who have early stage type 1 diabetes. And so typically trials will start right after the diagnosis of disease because it's much easier to implement these trials. And then additionally, when you're thinking about risk and benefits of these therapies, you want to really make sure that balance is optimized for these trial participants. And so we know that people after the diagnosis of disease, they for sure can benefit from something that's modifying disease and potentially could increase their endogenous insulin secretion. And so this is typically how you'll see these progress. First, investigators will test the new onset population, and then if they see an efficacy signal, usually based on C-peptide area under the curve from a mixed meal tolerance test, they'll move on to the prevention studies and test that population. So the first intervention that I'm going to talk about is Teplizumab, or anti-CD3. This drug is an IV infusion of a monoclonal antibody to CD3, which is a surface molecule in T cells. And so the idea behind this treatment is that you kind of deplete someone's T cells and then let them recover. And then efficacy studies have shown that this is associated with recovery of T cells that have a partially exhausted phenotype, and hopefully depletion of those autoimmune, autoreactive T cells. Some side effects of this drug can include a rash that can be pretty symptomatic, and then rarely patients can have cytokine release syndrome. So this is the kind of big survival curve graph from the Teplizumab prevention study. Just to remind everyone, this was a prospective randomized controlled trial that tested treatment with Teplizumab in people who were met criteria for stage 2 type 1 diabetes. So they were adults and kids, at least 8 years of age. They had at least 2 islet autoantibodies and were dysglycemic on an oral glucose tolerance test. This was done through the TrialNet consortium. So these are all people with relatives with type 1 diabetes. And again, this trial just tested a one-time course of this drug. So it was a 14-day IV infusion with Teplizumab. And on the right side of the screen, you can see the survival curve for proportion T1D free for placebo in black and Teplizumab in pink. And this trial ended up showing that with further follow-up data, Teplizumab was associated in about a 32.5-month delay in these at-risk relatives compared to placebo. So based on this data, this was the first drug that was approved to delay the onset of type 1 diabetes in this kind of class of agents. So this was really big news in our field. This happened in November of 2022. And this is now clinically available to patients in the United States who meet the enrollment criteria for the prevention study. So what are next steps in Teplizumab? For at-risk individuals or people with early stage type 1 diabetes, a big question is, what about younger kids? So the trial only went down to age 8, but I think, people who follow the at-risk population or natural history studies know that younger kids present with really rapidly progressing type 1 diabetes. This is a population that could definitely benefit from an almost 3-year delay in starting insulin. And so everyone's kind of really interested in understanding the safety of this drug in this population. And so Prevention Bio is actually currently doing a safety and pharmacokinetic study in that population to potentially extend that FDA indication to younger children. I think there's also a lot of interest in understanding what features are associated with better treatment response, so that we can really optimize dosing of this agent. And then there's also the PROTECT study going on. Maybe people who are on this call are involved in that study, but it's testing the efficacy of this drug using 2 different doses people who are recently diagnosed with type 1 diabetes. So enrollment's closed, and probably over the next year, we're going to hear results from that study. And it'll be really interesting to see if it's a positive study, if the FDA indication gets expanded to include onset of disease. So the next drug I'm going to talk about is ATG, or Antithymocyte Globulin. This drug involves 2 IV infusions to dose it. And the idea of how it works is kind of actually very similar to Teplizumab, where you kind of deplete somebody's T cells, allow them to recover, and hopefully those pathogenic T cells don't come back. So side effects of this drug actually can include the serum sickness that impacts a pretty significant proportion of the people that you treat, and can require treatment with steroids, but not everybody, but that's something to think about. So here's the kind of big picture, or the big data from the ATG study. This was a study that was done by TrialNet in people with recent onset disease, and the age range was 12 to 45. On the left side of the screen, you can see the C-peptide area under the curve over the course of the study. And this trial actually tested 3 different treatments, ATG and GCSF, which is shown in green, and then ATG by itself versus placebo. Placebo is in red and ATG is in blue. And so the intervention that showed the most efficacy in this trial was ATG alone. So you can see over the course of the study, the C-peptide area under the curve was improved compared to the placebo group. And then on the right side of the screen, you can see the hemoglobin A1C values from this study. And so consistent with the improved insulin secretion in the group taking ATG, hemoglobin A1C values were lowest in that group. So again, shown in blue compared to placebo in red. So what's next for ATG? The results in the T1D new-onset study are being followed up by the Enodia Consortium in Europe. So we'll see if that gets verified. And then TrialNet is actually undertaking a prevention trial using this agent currently in individuals meeting stage 2 criteria. So very similar individuals to who we treated in the Teplizumab prevention trial. So next I'm going to talk about Verapamil. This has gotten a lot of press recently, and actually this drug was really kind of championed by Antithymocyte and HIRN initially, where she kind of discovered as part of a drug screen that it was able to inhibit this protein that she's been really interested in, thyrodoxine interacting protein, or TXNIP, with the idea that if you could inhibit TXNIP, which is kind of involved in beta cell oxidative stress, it would promote beta cell survival. So Verapamil has been around for a long time. It's an oral calcium channel blocker and is typically or traditionally used for blood pressure. And so you have to monitor blood pressure pretty closely, especially in kids who are getting Verapamil, because it could potentially cause low blood pressures. And then because it's a calcium channel blocker, it can cause problems with your heart rhythm. And so you have to do EKG monitoring for that. So here are data from 2 different trials testing Verapamil. The first was the trial that Antithymocyte did in adults with recent onset type 1 diabetes. You can see in the Verapamil group in red compared to placebo, there was preserved C-peptide area under the curve over a year's time. And then more recently, this data has been recapitulated in children in the CLEVER study. And here you can see the C-peptide area under the curve data for this study with Verapamil in blue and placebo in yellow. And you can see again that the treatment with this oral medication was able to preserve C-peptide secretion significantly compared to placebo. So what's next in this area? I think there's a lot of interest in really making sure we understand the mechanisms of action of how this drug is acting in type 1 diabetes. So Anant's initial data suggested that it was working on TXNIP, but subsequent studies that they did using kind of unbiased approaches in the original adult Verapamil study showed that there's probably also an effect on T follicular helper cells, and also showed that chromogranin A is actually a marker that was improved by Verapamil treatment compared to placebo. So I think it'll be really interesting to follow up these kind of mechanistic analyses in the CLEVER study. Additionally, a follow-up adult study is underway in the Enodia Consortium, and long-term follow-up of the pediatric CLEVER study participants is ongoing. But I think given the really great safety profile of this drug and how easy it is to take, and that it's not working as immunomodulation, there's a lot of interest in extending this prevention and potentially as a combination therapy with some of these immune agents. Okay, so I wanted to end with a drug that we're testing at IU. It's very cool. It's very like bench to bedside story, and started with work in Raghu Mirmir's lab that was really focused on the polyamine biosynthesis pathway. And so for people who aren't familiar with polyamines, these are these kind of tightly regulated amines that are important in lots of different cell functions. Here's the entire pathway. But in beta cells, they're really linked to this kind of negative cytokine-induced inflammatory response, and specifically the impacts on translation that happen. And so Raghu's lab and subsequently we have been really interested in testing this drug DFMO, or difluoromethylornithine, which is an irreversible inhibitor of the first enzyme in this polyamine biosynthesis pathway, ODC, or ornithine decarboxylase. And so why are we so interested in this drug? Well, Raghu's data suggested that administration of this drug in preclinical mouse models of type 1 diabetes improves beta cell health and function and delays disease. And then it's actually been pretty well studied in the past. So IV administration is FDA approved to treat African sleeping sickness, or trypanosomiasis. And there have been a lot of research studies looking at oral administration in cancer prevention and treatment, including in little kids with neuroblastoma. So there's a really well-known safety profile that is not too bad, especially at lower doses. And so we were really interested in the idea if this drug could be used to improve beta cell health in type 1 diabetes. And so this was a study that was initially spearheaded by Linda D'Ameglio that was designed really as a dose-finding safety study that used treatment with this drug, again, an oral medication by mouth for 3 months, and then follow-up monitoring for 3 months with mixed meal tolerance testing and safety monitoring throughout. We tested 5 escalating doses and had 41 total participants that were kids and adults with recent onset type 1 diabetes. And so we were really excited that not only was the drug safe and really well tolerated by all of the participants at all of the doses, the kind of only side effects were some mild GI side effects. And some of the participants had mild anemia that I think is probably mostly related to lots of blood draws on the study and not the drug, because it improved on drug. Additionally, we had one person who had an allergic reaction and so had to stop taking drug, but overall otherwise was well tolerated. And then even though we had pretty small numbers, there was kind of an efficacy signal as well, which we were really excited about. Here you can see the C-peptide area under the curve values for the placebo group and then 2 highest dosing groups. And on the left side of the screen, the placebo group, as you would expect over time, is kind of losing C-peptide, but the 2 highest dose groups had kind of more stable C-peptide over the course of the study. So based on this, JDRF is funding a bigger trial that we're leading. That's a 6-site study testing this agent in children and adults with recent onset diabetes. Because of our safety data, we're using the bigger dose of drug and a little bit longer treatment to see if we can get more of an effect, and then doing mixed meal tolerance tests for metabolic monitoring throughout. So I want to just take a minute to talk about some challenges in the field moving forward. I think a big one here is these trials, these prevention trials in people with early stage disease or at-risk individuals are really hard to implement. They take a long time when you're doing a time to event trial, kind of waiting for people to develop diabetes, and it's really hard to find these participants. And so this is ultimately limiting the number of studies that we can perform in this space. And then practically, you know, I'm a big fan of Teplizumab. I think it's great that it was FDA approved, but this is kind of another logistic challenge that some of these individuals may choose to kind of pursue clinical treatment rather than enroll in a new trial where they might get placebo. So it kind of makes us have to think about the way that we're designing these trials. So, you know, what are kind of things that we can do to help with this? So one, I think Richard talked about screening, but we really need to think about ways to broaden these screening efforts, including people in the general population who are going to be most of the people who ultimately get diabetes. So, you know, we can really help the people who stand to benefit from these kinds of interventions and trials. And then relevant to people who are islet biologists, I think measures of beta cell function and biomarkers that kind of help us understand beta cell health could really be useful in this area. You know, if we had measures that kind of let us know that beta cells are under active attack, they can really give us an idea about who's at the highest risk for progression to clinical disease. And then these kinds of measures can also really serve as a readout of an early treatment effect. So these are data from the Teplizumab study as an example, looking at the C-peptide from participants in the study kind of before and after they entered the trial. And you can see for both the Teplizumab and the placebo groups in the period before the study started, they were losing their insulin secretion over time. These are really high-risk individuals. They're about to develop diabetes. And then this kind of process continued over time for the individuals in the placebo group, shown in black. But for the Teplizumab group, you can see this really cool reversal of their insulin secretion, where at 3 and 6 months, they had this increase in insulin secretion over time that was significantly different compared to placebo. And then especially if you're considering markers that incorporate both C-peptide and glucose changes, you can see, you know, this study, you could tell there is an effect of this drug at this 3-month time point. You know, you really didn't have to wait for the kind of 8 to 9 years that it took to implement the full time to event study to see that the drug was having an effect. Okay, so another big question is, how can we optimize treatment responses? So there are a few things we can think about here. One is that, you know, probably we're going to need to combine therapies that are targeting different mechanisms of action if we really want to get durable responses to these kinds of interventions. Another thing is that a lot of trials test just single dosing of these drugs, and it may be that we're going to need repeated dosing over time. And then it would be great if we could find ways to really optimize the timing of dosing for an individual, especially people who are at risk. And so, you know, ways that people in this consortium could be thinking about this is that agents that target different mechanisms of disease, like specifically beta cell agents, I think recently have really been showing some benefit, which is really exciting. And we need more of these kinds of options that we can think about. And then again, markers of beta cell function and health can give us a readout of active disease and give us insight into the need for repeated dosing or another treatment. I'm almost done. Okay, so this is another example of how I think beta cell markers can really help give us insights into some of these immunomodulatory therapies. This is data showing progression of type 1 diabetes in the Teplizumab prevention study based on what people's baseline at the time of study entry proinsulin to C-peptide ratio was. And for people who aren't familiar with this biomarker, which I've labeled here as PI to C for short, it's a ratio of the immature insulin to mature C-peptide in your blood. And so it can kind of serve as a readout of beta cell processing, which in some individuals is very elevated when beta cells are under a lot of stress. And so a high PI to C ratio is a readout of kind of active beta cell stress. And so you can see here for the Teplizumab study, when you kind of focus on people who started the study with the high PI to C ratio, so very elevated marker of beta cell stress, and you compare the placebo group to the Teplizumab group, placebo individuals are progressing really, really rapidly. Their average time to diabetes was 12 months here. And then you can see there's this kind of very clear separation and benefit for the Teplizumab treated group for these individuals who start with the high PI to C. Then if you take a look at the group with the low PI to C, you can see really both groups over time do significantly better. Eventually, you do see a separation of treatment groups. This wasn't statistically significant here, but I think you can see how, starting with high levels of beta cell stress, we can identify people who are really kind of standing to immediately benefit from dosing of drug. All right. And then, so what about this idea of differences in treatment responses? There's been a lot of kind of talk about disease heterogeneity and how this may be related to disease endotypes, which, the kind of idea behind endotypes is that eventually heterogeneity that we're seeing in phenotypes are linked to differences in treatment responses. And so I think an important question for investigators to study and address with this idea is, are any of these differences that we're seeing in phenotypes actually linked to differences in treatment responses? A lot of the kind of analyses that are linked to heterogeneity and phenotypes kind of don't take into consideration whether there actually is a difference in treatment response. And so this is something that I think is going to be really important to look at prospectively. We have a lot of kind of interesting post hoc analyses from studies that exist, but moving forward, it needs to be something we're kind of prospectively including in our study design. And then, a kind of major issue is that diversity in our studies is really limited to mostly kind of Caucasian, non-Hispanic populations. And so if we really want to understand disease heterogeneity, we need to have more diverse enrollment in these studies so that we can really understand what's happening in type 1 diabetes in everyone. Okay, so on to the conclusion slide. This is for the whole talk. I think it's a really exciting time in type 1 diabetes screening and disease modification. I think the Teplizumab approval was great, but it's really just the very beginning. I mean, there are so many interesting questions to study in this field, and we're really just getting started. So I think it's going to be really exciting. We have a cornucopia of different treatments to think about, and lots of people that we've identified through screening that can benefit. Yeah, and there are a lot of interesting questions and opportunities in this area. So that's it, and we can take questions.
We stop screen share.
Excellent. Thank you, Emily and Richard. Really interesting overviews from both of you. And we were fortunate that you're both up in a meeting in Vancouver, so you could be together. That's great for the Q&A. Okay, does anybody have any questions for Emily or Richard? If you do, you could come off mute. There's a comment from Eva. We'll get to that in a minute. Oh, there, Eva's raising her hand. Okay, go ahead, Eva.
Okay, did you unmute me? Thank you. Just because I've had nothing but computer trouble this morning. Okay, so the deal is, I think I know 3 or 4 people who are African American by half heritage and half white, or whatever, Caucasian, European. And so they have type 1 diabetes and they have sickle cell trait because of the combo marriage. And so I think I will look through all the research I have, and then I noticed, I think I saw Jim, was he on here, Jim Johnson? Anyway, if I could send it all to him, would that be okay? Because I kind of have a relation with him, and you mentioned Vancouver, so.
Yeah, we're actually in Jim Johnson's office, so we talk to him a lot. So yeah,
So
if you want to.
Is that okay? Just because I already have a link to him and I'm trying to pack boxes and move, so.
That's
when
totally okay. Yeah, I'm not aware of that association, but I think, as I mentioned, I think, first of all, in non-Caucasian populations, there's so much we have to learn about like disease pathogenesis and progression. And so, yeah, I mean, for sure, you could send him an email and tell him, that you were on the webinar and to touch base with us about it.
Yeah, with everybody, because I have my niece is working to get her fellowship completed in oncology, gynecology. However, she's brilliant at biochemistry. So why don't I send it through him? He's got so many contacts. I know he'll get it to the right place. Is that okay? Thank you so much. Yeah, only because I have so much information on Lexars, all I have to do is pull it all into one email or 2 emails or put it in the cloud. So thank you.
Thank you, Eva. That'd be great. And that's funny. They're in Jim's office right now. John, did you have a question? I saw your hand up for a minute.
Richard, I appreciate you saying something that I don't hear enough at colleagues when we go to these meetings, and that is that with the singles, as you said, there are more of them. And so because there are more of them, the numbers would get pretty close, if not, the same as multiples. So that philosophical wrestling that you need to do, I know that there are many of our colleagues that don't favor studying the singles for that reason, but I think it's still important. I mean, Emily, the type 1 trial net data, that the study that was published a couple years ago, it showed this flow chart, and it was 100-some thousand that were screened, but most of them, when they came up as singles, not doubles. So I think it's still an important thing. And Richard, I don't know how you're wrestling with it these days and what you're thinking about it.
So thanks, John. I think the important thing is to take pause and think, and to there are different ways to view single antibody positive. Remembering that most don't get type 1 diabetes, you could say, do they have autoimmunity, but it's regulated or not progressing, and is that interesting in itself? Or if you took a more a colder clinical kind of chemistry false positive negative view on type 1 diabetes as an outcome, you'd call it false positive because it's not disease relevant. In some ways, I don't mind too much, just as long as people think about where, what the average of the future holds for people you're studying who are singles. Also, there's another point that I glossed over in the interest of time, which is that we've simplified what is complicated information on progression of type 1 diabetes into 3 stages for very sensible, pragmatic reasons, that when you apply something in a healthcare system, you have to simplify it to make it kind of practically workable. But the reality is that the different autoantibodies, their characteristics, their titers, when they appear, other risk factors, other beta cell markers, all influence progression to risk, and that there's a good chance that you can identify riskier singles, or potentially people who are single antibody positive have the same risk as multiples and maybe should be classified as stage 1 type 1 diabetes. And so there's much more nuance than was within the presentation about that. And both you and I have worked on genetic risk. Genetics definitely is a component of that, in fact, and you can use genetics to stratify singles into higher risk and lower risk, amongst other things. So I think the main, it's like you say, you could take a hard line view and focus on the multiples, but I don't mind people studying single antibody positive individuals as long as they think hard about the question they're asking and the meaning of abnormal findings in a group who, if just defined by single alone, especially single GAD positive, are likely not going to get type 1 diabetes clinically.
Terrific. Thanks, Richard.
Great, thank you, Richard. And I think in the interest of time that we will wrap up now. So thank you again to Dr. Sims and Dr. Oram. Great presentations, and we really appreciate it and hope to see you all again at a future webinar. Thank you very much.